Hello and welcome. Today we're diving deep into a fascinating, yet often overlooked, kidney disease, medullary cystic kidney disease, or MCKD. We'll explore its causes, how it affects the body, and what can be done to manage it. So, let's begin this journey into the world of MCKD. The etiology of MCKD is primarily genetic. It's considered a genetic disorder, meaning it is passed down through families. There are two main types, each linked to a different gene. MCKD1 is associated with mutations in the MEMC1 gene, while CKD2 is linked to mutations in the UMOD gene, which codes for remodulin, a protein abundant in the kidneys. These genetic defects disrupt the normal function and structure of the kidneys, eventually leading to the development of cysts and kidney failure. In some rare cases, MCKD may occur without a known family history, suggesting a spontaneous new mutation. Let's understand how MCD actually damages the kidneys. Pathophysiologically, the genetic defects in MCKD lead to the formation of cysts, predominantly in the medulla, the inner part of the kidney. These cysts are surrounded by inflammation and fibrosis, which is scarring of the kidney tissue. This progressive fibrosis causes the kidneys to shrink and lose their ability to filter waste and regulate fluids and electrolytes efficiently. Crucially, the impaired function involves both concentrating urine, leading to polyuria, excessive urination, and sodium wasting, contributing to dehydration and electrolyte imbalances. Over time, this leads to end-stage renal disease or kidney failure. Unfortunately, precise epidemiological data on MCKD is limited, largely because it is often misdiagnosed or underdiagnosed. It is a relatively rare condition. However, estimates suggest that it accounts for a small but significant proportion of cases of chronic kidney disease leading to kidney failure. It affects both men and women equally. The age of onset can vary, but symptoms often appear in young adulthood to middle age. Accurate tracking is challenging due to overlapping features with other kidney diseases. The signs and symptoms of MCKD can be subtle in the early stages, often making diagnosis difficult. Common initial symptoms include polyuria, or excessive urination, particularly at night, known as nocturia. This is due to the kidney's impaired ability to concentrate urine. Patients may also experience excessive thirst, fatigue, weakness, and muscle cramps, which result from electrolyte imbalances caused by sodium and salt wasting. As the disease progresses, symptoms of kidney failure may emerge, such as swelling in the legs and ankles, nausea, loss of appetite, and eventually high blood pressure. Diagnosing MCKD requires a combination of clinical evaluation, family history, and specific tests. A detailed family history is crucial to identify potential genetic inheritance. Blood and urine tests are performed to assess kidney function, electrolyte levels, and look for evidence of salt wasting. Renal ultrasound or CT scans may reveal the presence of cysts, though these may be small and difficult to detect in early stages. Genetic testing is the most definitive diagnostic tool, allowing for the identification of mutations in the MEMC1 or UO genes. Kidney biopsy may be performed in some cases to examine kidney tissue and rule out other potential causes. While there aren't strictly defined types beyond MCKD1 and MCD2 based on the causative gene, it's important to recognize the disease presence with variable phenotypes. Some individuals experience a more rapid progression to end-stage renal disease, while others may have a slower decline in kidney function. The severity and specific symptoms can vary even within the same family, likely influenced by other genetic and environmental factors. Currently, there is no cure for MCKD. Treatment focuses on managing symptoms, slowing disease progression, and addressing complications. Management strategies include maintaining adequate hydration to compensate for sodium and salt wasting, and a low-sodium diet may be recommended under medical supervision. Medications can help control blood pressure and manage electrolyte imbalances. Erythropoiesis-stimulating agents (ESAs) may be prescribed to treat anemia. Ultimately, as kidney function declines, dialysis or kidney transplantation becomes necessary to sustain life. Unfortunately, there is no known way to directly prevent MCKD as it is a genetically inherited condition. Genetic counseling is essential for individuals with a family history of MCKD who are considering having children. This helps them understand the risk of passing the gene mutation to their offspring and explore available reproductive options, such as preimplantation genetic diagnosis of GD. Early diagnosis and management of symptoms may help to slow disease progression, but it cannot prevent the underlying genetic defect. The prognosis for individuals with MCKD varies depending on the age of onset, the specific genetic mutation involved, and the effectiveness of management. The disease typically progresses to end-stage renal disease, requiring dialysis or kidney transplantation. However, with careful management of symptoms and complications, individuals can maintain a reasonable quality of life for many years. Recent research focuses on identifying novel therapeutic targets and developing gene therapies to correct the underlying genetic defect, offering hope for future treatments. Research is also ongoing to better understand the mechanisms driving cyst formation and fibrosis in MCKD, which may lead to new strategies to slow disease progression.